What's Up, Doc Mike? Public Health on Call, by Johns Hopkins Bloomberg School of Public Health. Today's topic for February 6, 2021, Do Pandemics Really End? What We Know from the 1918 Flu and a Brief History of Vaccine. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Graham Mooney and Jeremy Green, two Johns Hopkins historians. They discuss how the 1918 influenza pandemic ended and what that can tell us about the future, and of how vaccine resistance has been part of the culture as long as there have been vaccines. Let's listen.
Graham Mooney and Jeremy Green, thanks so much for joining me.
Thanks for having me.
Thanks for having us here, Stephanie.
So, Jeremy, I want to start with you. I want to talk about how pandemics end. I know we're not quite near the end yet, but I'm curious. I understand that 1918 got a lot worse before it got better. So can you tell us a little bit about that process?
So it's really important to focus on the stories we tell ourselves about ends of epidemics. We're much better at talking about beginnings than about endings. I think so much of the science of epidemiology and also popular concern in an epidemic like the one we're living through is on origins, right? Who was the patient zero? What were the vectors by which it spread? There's a lot of blame that gets laden in these stories of how epidemics begin. And yet there's a lot of important science of contact tracing that goes into it. The question of how epidemics end, though, I think is more often neglected or left to a relatively optimistic popular imagination that epidemics end with eradication, right? That the disease simply is gone. Either it burns its way through a community and just ends through some sort of natural process, or it is blocked through successful containment strategies and the ability to actually get the reproduction quotient down to a noble factor. But only a few epidemics in human history have been eradicated through intentional means. And so oftentimes when we tell stories about epidemics ending, what we're really talking about is the point at which we stop focusing on them, and that we is often a mainstream we, and it's often a we that is located in place and in social position. So, for example, the 1918 pandemic is thought to have gone through three major waves, but many historians who have revisited the epidemiology after this suggest that there are a higher number of deaths from flu and flu-like illnesses that happened in 1919 and 1920. And it may well be that there was a fourth wave and a fifth wave, and they just weren't perceived. They didn't provide a signal that we commented on as a pandemic in quite the same way. So even pinpointing exactly when the 1918 pandemic ends, it's easier to pinpoint the moment in which we stopped attending to it as a pandemic than the moment in which there was an absolute freedom from this particular biological scourge throughout the world. I think it becomes particularly instructive to look at a question like the AIDS epidemic, HIV/AIDS pandemic, which clearly was understood as a new emergent threat of infectious disease of global importance when it was first detected in the early 1980s. It was described in terms very similar to the way that, say, COVID-19 is described, a new, lethal, frightening infectious agent of significant epidemic spread. So at what point did the AIDS epidemic stop being an epidemic in the popular imagination? It still kills millions of people each year. We have not cured it. We don't have a vaccine for it, but it's become something that we have learned to live with, such that when people talk about AIDS in epidemic terms, they often talk in past tense. And so the same could be said even for polio, which we've had much more success in developing a vaccine with. But if you look at the question of when the polio epidemics ended, the real question is for whom and where. So on the one hand, there's a really important story that my colleague Dora Varga has developed about how it is that in the Cold War battles of medical interventions, socialist and communist countries actually did a better job deploying polio vaccines earlier than the United States, even though the United States was credited with helping to invent the first polio vaccine through the Salk vaccine. But Dora also points out that many people still live with the complications of polio, that there are still polio epidemics breaking out in certain parts of the world. And so to talk about the polio epidemic in the past tense is to use a kind of a mainstream narrative of an us that assumes a lot of things and is not actually historically true. Polio epidemics continue. So I think when we think about what this means for COVID-19, the real question is, what will happen when enough people are vaccinated within countries like the United States that the attention begins to shift away from calling a pandemic, even though it's still ravaging many parts of the world? And we don't have a good answer to that question yet.
Mm-hmm. So, Graham, he was talking about the vaccine, and I wanted to talk to you about vaccine hesitancy, because we think of that as a relatively modern notion, that there are people out there who should have the vaccine but aren't interested in getting the vaccine. And so talk to me about the history of that.
Yeah, thank you for that. And it is an important question, because one of the biological ways a pandemic ends is through herd immunity. And one of the ways we get to that point is through immunization and vaccination. So the idea of vaccination hesitancy is obviously very important. But you said in the question, we think of it as a modern thing. Well, the term vaccination hesitancy is very modern. It's quite recent, within the last decade or so that it's been employed and used. Previously, I think we would have termed it vaccination resistance rather than hesitancy. And that goes back a long way. It goes back to even before the first known vaccines for smallpox in the later 19th century, when you had inoculation, which was actually inoculating a person with an attenuated mild form of smallpox itself. And obviously people resisted the idea that they may actually contract smallpox and die from it. So there was kind of hesitancy towards that. But the formulation of the vaccine for smallpox in the later 18th century, early 19th century, which was developed from cowpox, was seen as being a very important step in the control of infectious disease. But it had a lot of, it faced a lot of resistance for a number of reasons. One of them was that in a lot of places, the operation was seen as being so effective that preventing smallpox that it was mandated. It became compulsory legislation in a lot of nation states from the early 19th century onwards. And a lot of people resisted having to do something by force of law. People could be prosecuted if they didn't have their babies vaccinated within 36 days, for example, or 6 months, or whatever the legislation said. So people resisted that. But also, the vaccine, the smallpox vaccine, was produced in an animal, in a cow or a horse, as the case may be. And some people were very suspicious of that. The idea that they would be asked to take it on a fluid that may prevent smallpox, but it was taken from an animal, and a diseased animal at that. So this confluence of bodily fluids, human and non-human, was seen in some way as being unnatural. So people resisted on those grounds. And another very, very important force for resistance was religious resistance. People believed that disease was a visitation from God. It was a divine retribution for sins committed. And they believed that vaccination was somehow interfering with the will of God in those respects. So you have a whole set of rational reasons for why people would want to be hesitant about what we now call hesitant about taking a vaccine.
Mm-hmm. What do you see parallels to today?
Well, I think all of those things I've just said are actually very significant in the present. We see people, not taking the vaccine because they don't want to be told what to do, in very much the same way as people don't want to, might not want to participate in social distancing measures because they see it as some form of infringement upon their freedom. And if that comes through legal means, then they're going to be resistant to that. People object to it on religious grounds as well, and not so much. I wouldn't say so much in terms of the exchange of bodily fluids, non-human and human bodily fluids, but definitely there's a disquiet or a discomfort about what is actually in the vaccine itself, and whether that's based on facts and actual knowledge about really what is in the vaccine. In some senses, that is beside the point. It's what people believe that actually counts. So there's a lot of work to do in terms of effective science communication to dispel some of the ideas about what is in the vaccine. And a lot of that distrust is, it has very different roots and very different origins, but some of it is to do with the mistrust of the medical and healthcare profession, particularly amongst black populations, people of colour, and minority populations who have been mistreated by the medical and public health profession in the past. And there's a lot of work to be done to regain that trust.
I'd like to pick up on the last comment Graham is making about mistrust, hesitancy, and access to public health and biomedical interventions by minority populations in the United States. And I think that there's a really concerning moment. I'm not quite sure how to frame this correctly, that one of the things that's been unusual about public discussion about racial healthcare disparities in the COVID-19 pandemic has been the ability to really flesh out the nature of a dual pandemic, of the pandemic of the virus, COVID-19, and of structural racism, partly because of the way events have unfolded over the past year. So that when we began reporting COVID pandemic outcomes by race and ethnicity and realizing just how severe these disparities were, in prior pandemics, oftentimes these kinds of differences are used as a reason to argue for some sort of innate biological difference between racial or ethnic groups, or even behavioral differences in ways that actually focus on blame for differences in health outcomes residing in the people themselves, right? It's been unusual in that we've managed to keep a window open in which we view health disparities as outcomes of structural racism rather than outcomes of individual health decisions. My fear in all of the discussion of the racial basis of vaccine hesitancy leading up to the vaccine campaign, it really sets up the closing of that window in which when we look a few months, a year down the line, and we continue to see disparities in COVID morbidity and mortality by race and ethnicity in the United States, that can be linked to vaccine hesitancy as a behaviorist explanation for that difference, right? That the disparities are now, whereas previously the disparities were an outcome of an unjust society, now the disparities are the outcome of poor decision-making on the part of individuals belonging to different social groups. And we've seen that kind of blame, that phenomena in which health disparities get boiled down to behaviorist explanations so many times before. And I'm hoping that there's some sort of inoculation against that racist explanation of public health in the present day. But I fear that we will see the closing of this window in which we see COVID in terms of structural racism and see it instead as yet another case of blaming minority populations for their poor health.
Mm-hmm. Well, this has been a fascinating conversation. I think I could interview you guys all day. Thanks so much for joining me, Graham Mooney and Jeremy Green.
Thanks so much, Stephanie.
Thank you, Stephanie.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Hagedor, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.